Now let us continue with chapter 66 of your Apurba Sastry Essentials of Microbiology, which is about Myxovirus infection of the respiratory tract. In this chapter, we will be previewing the Orthomyxoviridae and the Paramyxoviridae family of the viruses. In this video, we will be covering the Orthomyxoviridae family and the influenza virus, while the Paramyxoviridae family with the parainfluenza, mumps, and respiratory syncytial virus will be covered in the subsequent videos. Myxovirus are a group of viruses that bind to mucin receptors on the surface of RBCs. Myxo in Greek means mucin, resulting in clumping of RBCs together to cause hemagglutination. Most of the myxoviruses are respiratory pathogens. Myxoviruses are divided into two families, Orthomyxoviridae and Paramyxoviridae. Both differ from each other in various aspects. The most important difference is the presence of segmented RNA in Orthomyxoviridae family. Important human pathogens are Orthomyxoviridae, influenza virus cause upper respiratory tract infections, rarely can cause pneumonia. The Paramyxoviridae include several viruses like parainfluenza virus, which mainly causes laryngotracheobronchitis and other URTIs. Mumps virus, which causes parotitis in children, salivary gland infection, and rarely complications such as meningitis. The measles virus causes exanthematous lesions, can lead to rare but serious complication of CNS. Respiratory syncytial virus can cause acute bronchiolitis in infants. Metapneumovirus cause URTIs, and zoonotic paramyxovirus such as Nipah and Hendra virus mainly cause encephalitis. Now, the Orthomyxoviridae infections. Influenza virus are the members of Orthomyxoviridae family. They are one of the major cause of morbidity and mortality and have been responsible for several epidemics and pandemics in the respiratory diseases in the last 2 centuries. Influenza virus consists of four genera: influenza A, B, C, and D. Morphology: influenza virus are spherical in shape, measure about 180 to 120 nanometer in size. Helical symmetry comprised of helical nucleocapsid surrounded by an envelope. Viral RNA comprises of multiple segments of negative sense single-stranded RNA. Each segment codes for a specific viral protein having a specific function. Influenza A and B contain 8 segments of RNA. Influenza C and D contain 7 segments of RNA. The segment coding for neuraminidase is absent. Site of replication: RNA replication occurs typically in the nucleus in contrast to most other RNA virus which replicate in the cytoplasm. Viral protein: influenza virus contains 8 structural proteins PB1, 2, PA, NP, HA, NA, M1 and M2, and 2 non-structural proteins NS1 and NS2. P1, PB2 and PA are the polymerase proteins responsible for RNA transcription and replication. Nucleoprotein is the major captured protein associated with viral RNA to form a ribonucleoprotein RNP or nucleocapsid with a helical symmetry. In this figure, we can see the influenza virus schematic diagram. From outside to inside, we see the NA protein, M2 and M1 proteins, the HA proteins, the single-stranded RNA, 8 segments of single-stranded RNA can also be seen. The matrix protein M1 is the major viral protein. It forms shell protein layer underneath the envelope. M2 protein form ion channel in the envelope, helping the transport of molecules. Non-structural proteins: NS1 is an interferon antagonist and inhibits pre-mRNA splicing. NS2 helps in export of molecules across the nucleus. Hemagglutination HA and neuraminidase NA are the glycoproteins inserted into the lipid envelope. Envelope consists of a lipid envelope in which two types of glycoproteins are inserted: hemagglutinin HA and neuraminidase NA. Hemagglutinin is a triangular shaped peplomere. It binds to mucin or sialic acid receptors on the respiratory epithelial cells, thus facilitating the viral entry. Neuraminidase is a mushroom shaped, present fewer in number than HA. It is a sialidase enzyme that degrades the sialic acid receptors on the host cells. It facilitates release of virus particles from infected cell surface during budding process by preventing the self-aggregation of virions into the host cells. Na also helps the virus to pass through the mucin layer in the respiratory tract to reach the target epithelial cells. The antigenic subtypes and nomenclature. Based on RNP and M proteins, influenza virus are divided into four genera: A, B, C, and D. Subtypes based on HA and NA antigen. Influenza A has distinct 18H subtypes H1 to H18 and 11N subtypes N1 to N11. Most of the subtypes infect animals and but occasionally undergo genetic changes and infect humans to cause major epidemics and pandemics. For example, 6HAH1, 2, 3, 5, 7, and 9, and 2NA, N1, and N2 subtypes have been recovered from humans. Influenza B viruses are not classified into subtypes but have diverged into lineages. Currently circulating influenza type B virus belongs to either B Yamagata or B Victoria lineage. Influenza C virus is detected less frequently and usually causes mild infections, thus does not present public health importance. Influenza D virus primarily infects cattle and are not pathogenic to humans. The standard nomenclature system for influenza virus, any influenza virus isolate should be designated based on the following information. Influenza virus type, host indicated only for non-human origin, geographical origin, strain number, year of isolation, HANA subtype. For examples, the human strain influenza A Hong Kong 03 1968 H3N2 and non-human strain influenza A swine Lohau 15 1930 H1N1. Antigenic variation. Antigenic variation is the unique property of influenza virus which is due to the result of antigenic changes occurring in HA and NA papillomeres. It is of two types: antigenic drift and antigenic shift. Antigenic drift is the minor change occurring to the point mutation in the HA or NA gene, resulting in alteration of amino acid sequence of the antigenic sites on HA/NA, such that virus can partially escape recognition by host immune system. The new variant must sustain two or more mutations to become epidemiologically significant, seen in both influenza virus type A and B. Results in outbreaks and minor periodic epidemics. Antigenic drift occurs more frequently every 2 to 3 years. Antigenic shift. It is an abrupt, major, drastic, discontinuous variation in the sequence of a viral surface protein HA/NA that occurs due to genetic resortment between genomes of two or more influenza viruses infecting the same host cells, resulting in a new virus strain unrelated antigenically to the predecessor strains. Thus, antibodies developed against previous strain due to infection or vaccination become ineffective. It occurs only in influenza A virus. It results in pandemics and major epidemics like H1N1 pandemic of 2009, and antigenic shift occurs less frequently every 10 to 20 years. Now the pathogenesis. Transmission is transmitted by inhalation of respiratory droplets generated by coughing and sneezing. This mode can infect only those people who are within 1 meter distance. Second, via contact with surfaces of fomites infected with respiratory droplets and then touching nose, eyes or mouth. Target cell theory. Viral HA attaches to specific sialic acid receptors on the respiratory mucosa that leads to viral entry. Multiply locally. Virus replicates in the infected cells and infectious daughter virions spread to the adjacent of respiratory epithelial cells over several hours. Spread. Very rarely virus spreads to the lower respiratory tract or spills over bloodstream to involve extrapulmonary sites. Local damage. Influenza virus infection can cause cellular destruction and desquamation of the superficial mucosa of the respiratory tract, which may predispose to secondary bacterial infection. Now, the host immune response. Humoral immunity is the predominant immunity that provides resistance against influenza infections. Immunity is developed in both type and subtype specific and long lasting. Antibodies against HA and NA are protective in nature and are subtype specific. Antibodies to HA prevent initiation of the infection by inhibiting viral entry, whereas antibodies to NA decrease the severity of the disease and prevent the transmission of the virus to contacts. Antibodies against the other viral proteins are not protective. Antibodies against the ribonucleoprotein are type specific and are used in typing viral isolates as influenza A, B, or C. All the three types of influenza virus A, B, and C are antigenically unrelated and there is no cross protection. Immunity may be incomplete following influenza infection. Reinfection can occur within the same virus. Components of both cell-mediated immunity, examples cytotoxic T cells and innate immunity NK cells, interferons, are also important in providing immunity against influenza infections. Clinical manifestation. Incubation period is about 18 to 72 hours, which directly depends upon the inoculum size and immune status of the host. Uncomplicated influenza or the flu syndrome, majority of the individuals are either asymptomatic or develop minor upper respiratory symptoms such as chills, headache, and dry cough, followed by high grade fever, myalgia, and anorexia. It is a self limiting condition indistinguishable from the infections caused by other upper respiratory tract pathogens. Complications. Pneumonia, secondary bacterial pneumonia, is the most common complication to occur in patients infected with influenza virus. Common agents are staphylococci, pneumococci, and Haemophilus influenzae. Primary influenza pneumonia is rare but leads to more severe complications. Other respiratory tract complications include worsening of chronic obstructive pulmonary disease, exacerbation of chronic bronchitis, bronchiolitis, otitis media, parotitis, and asthma. Extrapulmonary complications include myositis, rhabdomyolysis, myocarditis, encephalitis, post-influenza Guillain-Barré syndrome. Ray's syndrome is a fatty degeneration of liver with acute encephalopathy occurring in children and adolescents 2 to 16 years of age following aspirin or salicylate intake. Though the cause is unknown, this condition is often seen following influenza B, varicella zoster, and rarely influenza A viral infections. Epidemiology. Influenza virus causes seasonal flu epidemics worldwide almost every year. However, they differ widely in severity and extent of the spread. Incidence. It is estimated that annually about 3 to 5 million cases of severe illness and 3 to 6 lakhs of deaths occur due to the seasonal flu epidemics worldwide and is associated with significant economic impact. Global pandemics of novel influenza A subtypes occur every 10 to 40 years, which can cause much higher mortality than seasonal flu. Seasonality. Influenza outbreaks are common during winters. Most common seasonal flu strain varies from season to season and from place to place. Example S3N2 in Puducherry in 2018. Annual attack rate about 5 to 10% in adults and 20 to 30% in children are infected annually. Epidemiological pattern depends upon the nature of the antigenic variation that occurs in the influenza types as described already. Now the risk factors. Following risk factors are important to determine the patients undergoing for complication of influenza. Age, child of age less than 2 years or age more than 65 years. Chronic disease like chronic pulmonary, cardiac, renal, hematologic, metabolic, neurological, and neurodevelopmental disorders. Immunosuppression including HIV/AIDS, use of long-term corticosteroids, post-transplant patients, diabetes mellitus. Other risk factors include extreme obesity, residing in nursing home, American Indians and Alaska Natives, and pregnancy. People with these risk factors are the first priority group for receiving influenza vaccination. History of influenza outbreaks. Till now, several influenza pandemics and major epidemics have occurred in worldwide. Seroarchaeology. The outbreaks that occurred prior to influenza isolation, influenza isolated first in 1933 using ferrets, were detected later by retrospective serologic survey of individuals alive during those years. The severe post-pandemic Spanish flu recorded so far was the swine flu strain H1N1 in 1918-19, where more than 50 million people died, mostly due to secondary bacterial pneumonia. This strain was not a resortant but believed to be derived entirely from an avian strain that had adapted to human conditions, and pigs acted as a mixing vessel. Okay, so there were several pandemics associated with several subtypes. Okay, now this was followed by a series of several epidemics and pandemics as mentioned. Now the sialic acid receptors. Sialic acid receptors found on the host cell surfaces are specific for HA antigen of influenza virus, which in turn determine the different host specificities of influenza virus. Alpha 26 sialic acid receptors are specific for human influenza strains and are found abundantly on human upper respiratory tract epithelium but not on lower respiratory tract. This explains why most human flu strains cause mild upper respiratory tract infections but not pneumonia. Alpha 23 sialic acid receptors are specific for avian influenza strains and are found abundantly on birds' intestinal epithelium. In humans, they are present in very few numbers on upper respiratory tract and also on some epithelial cells in the lower tract. This explains why avian flu strains cannot easily infect humans and needs close contact. However, once infected, they can infect the lower respiratory tract and cause pneumonia as well. Why pigs are most common mixing vessels, both alpha 23 and alpha 26 sialic acid receptors are found on the same respiratory epithelial cells of pig and swine flu strains, have specificity for both the receptor types. Hence, pigs can be infected simultaneously by human, swine, and avian strains, thus serving as a mixing vessel. Assortment between the segments of various strains can take place inside the same swine cell. Avian flu. Birds are the primary reservoir of influenza virus. All influenza subtypes 18H and 11N are found in birds, and some of the subtypes can be transmitted to mammals H1, 2, 3, 5, 7, and 11, 9 to humans, H1 and H3 to swine, and H3 and H7 to horses. Usually, the avian flu strains are highly virulent as they possess PB1F2 protein, which targets most mitochondria and induces apoptosis. Avian flu infection in birds. Bird flu strains are highly lethal to chickens and turkeys, but avirulent to ducks, and are the major cause of economic loss in poultry, causing severe mortality in chickens. Unlike in mammals, avian flu multiplies in intestinal tract of birds and shed through feces into water. Avian flu is a waterborne disease in birds. The influenza virus do not undergo antigenic variation in birds because of the short lifespan of birds. Avian flu infection in humans. It is believed that to date, all human pandemic strains have originated by resortment between avian and human influenza virus, and the mixing has occurred in pigs. A oblique H5N1 is the most common avian flu strain that has been endemic in the world for past 15 years. Origin was first reported from Hong Kong in 1997 and has spread to various countries including India within few years. Transmission to man occurs only from birds and requires close respiratory contact. Less morbidity but more mortality as there is no human to human transmission. Morbidity is less. However, the avian flu strains are highly virulent due to presence of PB1F2 protein and mortality rate is more than 60%. Globally, only 861 cases have been reported between 2003 and 2019, out of which about 455 people succumbed death, 52%. Clinical features. H5N1 avian flu strains are associated with higher rates of pneumonia and extrapulmonary manifestation such as diarrhea and CNS involvement. Other avian flu strains infecting humans are AH7N7 in Netherlands, AH9N2 in Hong Kong, AH7N9 caused outbreak in China in 2013. Now, the lab diagnosis of avian flu. Avian flu strains can be identified by real-time reverse transcriptase PCR detecting specific HA and NA genes. Now, influenza A H1N1 pandemic of 2009. It has caused the most recent pandemic of influenza emerged in California in March 2009 and then rapidly spread to the entire world including India. Over the next few months, WHO declared the pandemic on 11 June 2009. Epidemiology. Origin. H1N1 2009 flu originated by genetic reassortment of 4 strains, one human strain, 2 swine strains and 1 avian strain, and the mixing had occurred in pigs. Though people commonly use the word swine flu to describe H1N1 2009 flu, but it is not correct terminology as it is a resortment of 4 strains. Transmission can be transmitted from human to human, which has accounted for its rapid spread. However, it is less virulent as it lacks the PB1F2 protein. Therefore, in contrast to H5N1, the H1N1 2009 flu has caused more morbidity but less mortality. Clinical features. Uncomplicated influenza. Most of the cases present with mild upper respiratory tract illness and diarrhea. Complicated or severe influenza can occur very rarely in high risk groups, is characterized by features such as secondary bacterial pneumonia, dehydration, CNS involvement, and multi organ failure. Like in this, we can see the evolution of pandemic influenza virus. It came from the avian flu, the human flu virus, and the swine strains all mixed in pig, and the resortment in a swine host was there, which affected the novel human pandemic, which made a novel human pandemic virus. Okay, now the categorization of seasonal influenza A H1N1. Ministry of Health and Family Welfare, Government of India has published a guideline on categorization of seasonal influenza A H1N1 cases. While screening the patients with influenza-like illness, this guideline helps in taking decision on performing lab tests, initiating antiviral treatment, and putting on the patient on home isolation or hospitalization. Now, the epidemiological surveillance for influenza. Influenza surveillance is routinely carried out globally and also at national level. This helps to monitor the changes in the circulating influenza strain and serves as global alert mechanism for the emergence of pandemic influenza viruses. GISRS. Influenza surveillance has been conducted globally through the Global Influenza Surveillance and Response System GISRS under the World Health Organization WHO. IDSP Integrated Disease Surveillance Program under NCDC National Center for Disease Control conducts influenza H1N1 surveillance in India. India 2019, according to IDSP report 2019, 28,798 cases of H1N1 were reported with 1,218 deaths. Rajasthan reported the maximum cases, followed by Gujarat, whereas Maharashtra reported the maximum deaths. Mortality rate is around 4 to 5% every year. World, according to WHO, 3 to 6 lakh deaths occurred due to seasonal flu annually, 4.0 to 8.8 per 1 lakh population. Global pandemics of novel influenza A subtypes occur every 10 to 40 years, which can cause much higher mortality than seasonal flu. Now, this is the guideline for categorization of the seasonal flu by the Government of India. Category A definition: influenza like illness with mild fever, cough, sore throat with or without body ache, headache, diarrhea, and vomiting. Lab tests are for H1N1 not required, treatment only symptomatic, antiviral drugs not required, isolation confine the patients at home, avoid contact with public and high risk members of the family. Category B, category A plus any one of the following, like high grade fever and severe sore throat, or presence of any one of the risk factors like all the diabetes and hypertension, etc. Now, in this, lab testing for H1N1 is not required, but the treatment, symptomatic treatment is required. Antiviral drug oseltamivir may be required. Isolation, confine the patients at home, avoid contact with public and high risk members of the family. Category C, severe acute respiratory syndrome SARI. Category B plus any one, breathlessness, chest pain, fall in blood pressure, sputum mixed with blood, bluish discoloration of the nails, or children with influenza like illness who had a severe disease as manifested by the red flag signs, inability to feed well, convulsion, difficulty in breathing, etc., or worsening of the underlying chronic conditions. In this, lab testing for H1N1 is required, immediate hospitalization is required, treatment start antiviral drug oseltamivir immediately without waiting for lab result, and isolation all components of droplet precautions to be followed in this case. Real-time reverse transcriptase PCR is recommended to detect and quantify specific HA and NA antigens of H1N1, and oseltamivir Tamiflu tablet of zanamivir or zanamivir inhalational form tablet can be used. Now coming on to the lab diagnosis part of Haemophilus of the influenza virus. Lab diagnosis: specimen, nasopharyngeal swab kept at 4 degrees Celsius. Isolation of virus, inoculation of embryonated eggs and primary monkey kidney cell lines. Growth is detected by heme adsorption, hemagglutination test. Viral antigen detection by direct immunofluorescence test. Molecular methods simultaneously detect seasonal flu strains such as A H1N1, A H3N2, and influenza B. RT-PCR detects viral RNA. Real-time PCR quantifies viral RNA, and antibody detection by hemagglutination inhibition test, neutralization test, and ELISA is also done.